Hi, Sylvia. Thank you so much for hanging out with me for a little bit today. I just wanted a chance to introduce what your interests are and what exciting things that you are doing at Washington University in St. Louis so that my Japanese colleagues can get to know you a little bit more. So if you don't mind, please share with us what your current responsibilities are at WashU.
Sure. Yeah. First of all, Michael, I just want to say thanks for inviting me to do this. I think this is a great opportunity, and I appreciate the invitation. So right now at WashU, I spend about 50% of my time teaching and 50% of my time in clinical practice. So from a standpoint of teaching, I'm primarily in orthopedic content. So that may be teaching about management of orthopedic conditions. In terms of clinical work, it's the same. I'm in outpatient orthopedics. I enjoy treating knees the most, but I treat pretty much everything head to toe that comes in the clinic, like most outpatient therapists, but I do have a special interest in knees.
Excellent, excellent. And I know that it's, as a physical therapist, we have so many different things that we can do, but did you always know that you wanted to become an educator?
Definitely not. I wasn't also one of those people that always knew that I wanted to be a PT either. That was kind of like one of those happenstance types of things, but we can probably get into that later. But in terms of an educator, no, I knew that once I graduated PT school, I took a clinical student almost right away. There was somebody that needed a clinical remediation and I was asked to do it. And I said yes, because, you know, it was a great opportunity. And I really enjoyed that experience. And that kind of led me into thinking, well, maybe I should lab assist some classes. I mean, I was working at the Rehab Institute of St. Louis, which was right next door to the program. And after you're out about a year, WashU likes to allow you to lab assist. They want you to kind of get your feet wet with a year of clinical experience first. And so after that first year, it's like, all right, I'll lab assist a couple of the first year classes where they're learning like goniometry or manual muscle testing or transfers and gait. And I found that I really enjoyed it. There's something about working with students that it's not that we don't know why we're doing something, but to have to explain it to somebody, to explain your clinical reasoning or like why you, we'll call it, why we take clinical shortcuts like we do when we're in the clinic compared to the way students are taught very specific like orders of things. Like, I don't know about you, but I bet neither one of us manual muscle tests the way that we teach our first year students. So like but we explain to them why we take those shortcuts and why we can and why we're still getting, you know, accurate information. But that whole first year of lab assisting, that experience made me realize I really enjoy sharing the knowledge that I have, but also being able to get questions from them and remind myself of that curiosity that I once had too as a student, you know, and that passion for wanting to know more. It was really exhilarating.
Yeah, that's great. And I think it always keeps you on your toes when you're in the position to explain something, because you don't want to just say, well, this is the way it is. You have to have a good reason
Absolutely.
for why you did what and your thought process. So
absolutely.
Yeah. So two things. What's been the most challenging things and what's been the most rewarding things about teaching the DPT curriculum students since the pandemic started? I can't imagine what the faculty's been through these last couple of years.
Wow. Well, yeah, so there's a lot in that question because there's been a lot going on since the pandemic started. So for me, I primarily teach in our second year curriculum. So back when the pandemic started, our second year students had just come back from clinical rotations. They were in class for maybe a week. And then I left to go on my kids' spring break, and that was the week that everything shut down. Essentially, we had to pivot in about 4 days. Everything that we would have done in person had to go online. We had like, I think the program closed for 2 days and then the weekend. And then Monday we were back online again. That was unlike the undergraduate campus and the medical school because that was their spring break. So the week that everything got shut down was also the week that the med school had that week already. So they had a longer period of time of turnaround than we did. So the challenging aspect of that was trying to figure out, we're a hands-on profession. how are we going to take this stuff that they would normally practice hands-on and give them the confidence that they can still do it when we have absolutely zero labs in that spring semester in person? Because we didn't start in-person things back up until the late summer and the early fall. But they still had to learn. They were going through the ankle, foot, the elbow, wrist, and hand, and cervical thoracic units for us for just my orthopedic content. And then they had a whole host of neurologic content that they were getting in cardiopulm and all those. So I think the most challenging part was trying to figure out how we could replicate those experiences. I think the second part was in the orthopedic content in particular, we had a lot of patient labs. It's really hard to understand what a real patient looks like until you see a real patient, especially for like hand conditions. I feel like they're also less common. It's harder to find patients. You go on a clinical rotation, you might not see a hand in a standard outpatient orthopedic clinic for months, right? Unless it's like a tennis elbow, and that doesn't totally count. But so it was also trying to give them patient experiences so they could get what does it really look like when somebody has, like a lacerated flexor tendon? What can they do? What can't they do? Or like, a complex injury, a crush injury or whatever. So that was probably the second hardest part about it. And I think kind of the last part about it that was hard, which oddly I didn't list first, was just even the didactic content. So we're used to having the students in class for like, they would sit in lecture for like 2 hours, they'd have a break, they get another chunk of, lecture, and then they go to lab. And it was like, well, I can't just have them watch a lecture for 2 hours live on Zoom. That's not going to work really well. So we had to figure out ways to deliver the didactic content that they would have been getting live to the students. So most of that did initially end up being recorded lectures from previous years. It's not a great solution, but what can you do in 4 days when you're trying to turn it around? So subsequent years, we were like, we can't do that again. That was awful because students would, like in the recorded videos, people would ask questions. You couldn't hear any of the questions and then it would be answered. It was just a really poor learning experience for them, but it's what we had to do to survive at the beginning. Once we had a summer-ish to kind of like retool lectures, it was like, okay, we still can't have them in the classroom 100% of the time. How can I take that 2-hour lecture content, truncate it down? And that's when we had to really force ourselves to figure out, what are we teaching that is need to know material that these students absolutely need to know to pass their boards, to be an entry-level clinician? And how much of this content has been stuff that we're teaching because it's like, oh, this is a great clinical pearl, I want you to know. Or I think this is really interesting because it's my favorite body part and I really want you to know it because I like it. So we had to kind of divide out that nice to know, need to know. And I think that was extraordinarily challenging for all of us. But in the long run, I think what has been great about that is we were forced to relook at what we're teaching, and like it helps us understand, wow, we've been burdening the students maybe with a lot more than they needed to know to be entry-level clinicians. So it's allowed us, as we've been reviewing and redoing the curriculum a little bit, to focus more on those types of things versus kind of some of this extraneous information, which, while important and interesting, maybe isn't what they need to know right now. So that requirement of like a change in the way we're thinking has actually been really rewarding, because it's like, oh, one, look at all the stuff that we've been teaching them that, folks like you and I had to go through, and we probably learned a lot more than we needed to for entry-level clinicians. But how am I doing a better job of efficiently presenting the information they need to know? What am I going to keep from all this stuff that we taught online? We have so many we have like telehealth videos now with patient consent that we can use as teaching tools. We have so many different videos of things that we didn't have videos from before. So when students had to learn how to do, I don't know, they were learning, let's say, grip dynamometry, for example. We didn't used to have videos for that because they just show up in class, we demonstrated, and then they practice. Well, in the era of COVID, we didn't have videos. So we had to make videos. We had to show standardized or performance of it. And now the students have those as references for when they're studying. Even though they come back and they learn it live now, they have so many more resources for learning, and even like going back and being able to review those lectures videos that are now truncated. So now they don't have to watch a 2-hour video to get the gist of it. Maybe they're only watching an hour's worth of video on the same content, so they can go back at their own leisure. So it was a process, and it was awful to be in the process, but I think the product after the fact has been really pretty nice. It has been really nice. And to see that our students still came out with the level of knowledge that we wanted them to. Maybe the skills weren't as good because they didn't have the opportunity initially to practice, but we found ways to bring them back to allow them to practice those skills that they otherwise would have they missed in that first spring.
That is absolutely amazing to hear that behind the scenes stuff, what you guys were trying to prepare, so that the quality of education wasn't compromised. And in the midst of all this, I know that WashU PT went through a whole curriculum change.
Yeah, so then there was that. So WashU had already planned to do this like curriculum renewal, which for people that don't understand, why on earth are you going to redo your curriculum? I mean, we've been teaching in the same way for years, and there's not anything wrong with it, right? Like we're still one of, the top program in the nation. But we always feel this drive, like we can do better, like we can make it even better. And so this idea is we hadn't really thought critically about the way we were teaching, the order in which we teach material, how we're teaching that material in quite some time. And so the decision was made before the pandemic to do this curriculum renewal, and it was rolling out in the fall of 2022 or 2021. And the decision, even when the pandemic hit, was, well, we're rolling out regardless. So the added challenge for us is in the process of taking current content and current classes and turning it into an online program, and then adapting as some of the precautions were lifted from the standpoint of we could get back into the classroom again. We were also working behind the scenes, and still are, to reorganize and repackage the curriculum for the students that just went through in the fall and that are here in the spring as well. So we're in our first cohort, still in the process of doing that. So it's like a never ending process. It has been rewarding, but the process I can't say that I've loved. The end product, sure, but the process, not so much.
Well, if anybody can do it, it's the faculty at WashU PT, because everybody in that family just really cares about students and sort of supporting, new PTs coming out with strong, solid base of knowledge. So
absolutely,
I'm happy to be, sort of within that family. I want to take you back a little bit to the roots of things. How did you decide to become a physical therapist?
So I am not one of those people that has that injury story. Like I was injured, I went to a PT and it opened my eyes into the PT world. It's actually way less dramatic than that, and slightly embarrassing, but not terribly to tell. So I had no idea what I wanted to do. I knew health professions I enjoyed. My mom's a pharmacist, but I didn't want to do that. And my dad's an aerospace engineer, and I definitely didn't want to do that. But I like gravitated towards the sciences. At some point during my college career, my dad realized I was going to be able to graduate a year early from college. And so he's like, I'm not paying for an extra year of college, and I don't want you taking out loans. So what do you want to do with your life? And I thought I had 2 more years to figure that out. Now I only had 1 year to figure it out. So I panicked. My best friend is actually, she had known that she wanted to be a PT her entire life. She was like, I'm going to be a PT. I'm going to be a PT. And she actually went through the entry level master's program at West Virginia University. And so I like called her up and was like, Becky, tell me a little bit about PT. What's the deal? And she explained it. And I was like, okay, that sounds pretty cool. I'm going to start volunteering. So that summer, before I was applying to PT schools, I spent the entire summer volunteering in as many settings as I could. So I ended up at a hospital and an outpatient ortho setting. And I got to see wound care. I got to see acute care. I got to see whirlpool treatments for wound care, which was like, ugh. And then in outpatient ortho, I was at a clinic that saw orthopedic patients. I saw lymphedema patients. So I saw a little bit of like everything. And after that summer, I was like, I mean, I had like a PT intensive. It was like, a couple of months of just PT. I was like volunteering 40 hours a week almost. And I was like, I love this. I love everything about it. I loved what I saw. And so I'm like, I hope that this is what I want to do with my life. I applied to PT schools. I got in at WashU, and then the rest is history. And I found out pretty quickly that I had made the right career choice. Thank goodness. So yeah, I love what I do. I'm so thankful that just, again, that happenstance conversation with my friend Becky. She was so passionate about it, and she is still a PT. She's still practicing, so it's great.
Well, we're forever grateful to your best friend, Becky. And gosh, did you grow up in St. Louis? Because I know that you went to undergrad at WashU. You're like WashU through and through.
I am WashU through and through. So I grew up in Maryland, actually, and then went to WashU as an undergraduate. I got my master's from WashU and then went back and got my post-professional doctorate from WashU. So I am WashU 100% through and through, but I am originally from Maryland.
I see. Wow. That's a big jump coming from the East Coast. I'm sure there were lots of culture shock and
there's definitely differences in East Coast versus Midwest like style. Like I feel like these are all going to be horrible stereotypes, but like East Coast, it's a little bit more uptight. It's a little bit more intense. And then Midwest seems a little bit more casual. Driving in the Midwest, way worse, especially if there's like any drops of rain or snow or anything on the ground compared to like East Coast. They deal with the weather, I think, a little bit better. But yes, I mean, so there's pros and cons. Cost of living's way better in the Midwest than it was on the East Coast. You know, I can't complain about gas prices either in the Midwest. So there's definitely pros and cons. But I enjoy it here, and I'm going to be here. Like I love WashU. I'm going to be here until I retire easily.
well, that's a relief to hear. So as we go through our career, we get influenced by a lot of different people, but who are some of your key mentors, who really influenced you in your career as a PT? And particularly because I know you have a strong interest in the knees and the ACL topics.
Yeah, so it's interesting because I think there's different parts of that, because I think we have mentors that can mentor you from like a clinician and your skills as a clinician standpoint. And then you have mentors from the standpoint for me academically, like who's helping me when it comes to progression on the academic ladder. And in terms of like my growth as a person and my ability to have confidence in what I'm capable of doing and what I've always been capable of doing, it's always been Marcy Harris Hayes. When I was, of all things, she was our graduation speaker when I graduated at WashU PT. And I just love Marcy anyway. I've had both of my ACLs reconstructed. She was my therapist when I had my ACL reconstructed in PT school. And she and I, we would talk, we would share stories. I dog sat for her. And after I graduated and eventually came back and did my post-professional DPT, we had to do that capstone project, which is sort of like the culmination, the final project. And she was my advisor. I asked her to help me out. I was doing a review on ACL stuff. And I thought that was it. I just needed to do this project to graduate, right? Like I'm thinking like a true student. Marcy's like, no, I think you can get more out of that. And what I got out of it was a poster at CSM. I got a systematic review published in the British Journal of Sports Medicine out of it. These are all things that Marcy was like, you're settling for too little right now, Sylvia. This is really good. You can do more with it. So I've always credited Marcy, and I will, and every time anybody asks me like who's the biggest influence on where you are right now, 100% it is Marcy. If it was not for her, I would not have presented to our education session at CSM, because I was panicked when she asked me about doing it, and I was like, all right, fine, I'll do it because you have the confidence that I can do it. So she has been the most amazing, and I still go back to her periodically if I need a little bit of like a Marcy, I need a common sense gut check here, and she's just always been so wonderfully positive. In terms of ACL stuff, it's been really interesting because at WashU, we are not known for our ACL, like ACL research, for example. Like it's not like if you went to Delaware, University of Delaware, or Pittsburgh, or something like places that are definitely more well known. I would say that in terms of influence from a research standpoint, I think anybody would be completely ignorant if they didn't say that they weren't influenced by Lynn Snyder Mackler and all the research that her lab has put out about the ACL. I mean, it would be completely remiss if we didn't mention some of that work that she has done and continues to do. I think for me, some of the other things that have really interested me in the ACL world has been a lot about kinesiophobia. So I find the most fascinating part of ACL rehab is you could take 20 people that look the exact same, had the exact same injury, surgery, pre-injury activity level or whatever, and every other thing aside, you're going to find different outcomes in like all of them. And some of it, I feel like you've got one person that almost passes out on the first day of rehab, the other person that's like walking without crutches 2 days post-op, the other one you can't get off 4 weeks at post-op. And it's like, what differentiates them? And it's the psychosocial elements of it that I think we underestimate. So from that standpoint, early when I was getting interested into the ACL stuff, and this is actually what came from some of the poster I did at CSM, the platform I did at CSM, and the systematic review, was early work from Trevor Lentz, who still works in fear avoidance literature. I think he just had something published in JSPT about it, but talking about the Tampa scale of kinesiophobia and scores on that, which predicts outcomes in people following ACL reconstruction. Therese Shimaleski, and I apologize if I just butchered her last name, she's done a lot of work as well on the Tampa scale of kinesiophobia. Kate Webster has done a lot with the ACL RSI. So those folks that work to quantify what I was seeing and putting it in some kind of standardized scale, like a patient-reported outcome scale, that could be used to help identify, I don't want to call them cutoffs because that's probably not the best way to describe it. I know they've talked about that in the literature, but just people that are probably gonna be more likely returning to prior level of function and prior level of sport versus less likely to do so. And so being able to just follow the evolution of that literature has been very influential on how I practice as a clinician as we're learning more about those elements. And I think just clinically, just hearing now people like Dusty Grooms, who talks about all the neurocognitive elements of rehabilitation and how dual tasking and all this stuff that I was like, oh, I can forget about it because it's neuro related. I don't treat neuro patients, but like learning about those things in the application to the ACL population have been immensely influential to me as well. So there's a lot of names. I think like Claire Ardern also did some things related to ACL rehabilitation. There's just so many names, and I've been extremely fortunate to meet just about, I think, all of them at some point in time. And it's been wonderful to just kind of pick their brains about different things. So.
Yes, well, I did a presentation about phases of tissue healing, the tissue impairment movement system diagnosis last year, and there was a request from the members about, can we learn more about ACL? And I just was like, okay, well, I don't feel equipped to talk about ACL as much. And I was like, who can I ask? And you know, you're so just everywhere on the Twitter world. And I know that you are well connected, and I know you're, you know, do an amazing job with lecturing about the topic. So I am super excited to have you come on to the Movement System monthly lecture in actually for 2 months, because you had sent me this like nice categories, and I was like, well, can we do it all?
And I'm like, not in like 2 hours, Micah, are you crazy? Yeah, I'm really excited to do it too, because you know, one of the things that when I've given talks about ACL, we realize everybody doesn't work out of like a lab that has 3D fancy motion capture, right? That doesn't have force plates, that may or may not even have a dynamometer, right? Like that they can use to measure the torque. So I think it's really important to make sure that the basics are being covered. Even like, I know we talked about like range of motion. Like, is hyperextension a good thing or a bad thing in a knee? Like, there's a debate about that, and open kinetic chain versus closed kinetic chain. There's actually still debate about certain things that we really probably shouldn't be debating anymore. And unfortunately, it is kind of still out there. And I think we need to do a better job of dispelling those myths wherever we can. And that's been part of my goal, is to just educate the everyday therapist that's going to see the everyday athlete, not the rock star, you know, like professional tennis player, professional athlete, like just like the average Joe that tore it while they, well, you probably got strange ACL stories. Like they tore it when they got flown off a mechanical bull while they were drunk at a bar. Like that was one of my, I had another lady who tore it. She was in a mosh pit and they dropped her, and didn't tell her there. I mean, like stuff like that, but like people that didn't expect to like have an injury like that, and now they're recovering for it. What do you do with those folks? Like, how do you give them the best outcome to get back to their prior level of function as well?
Mm-hmm. Yeah, well, it's an exciting topic. Whenever we go to conferences, ACL seminar rooms are always packed. And so I hope there will be lots of people signing up for this, and you'll be coming on in April and May. So thank you so much for sharing with us your expertise, and we're really looking forward to it.
I'm looking forward to it as well. I think it'll be really great. I really do.
Well, thank you so much, Sylvia, for today, and we will see you in the near future.
Sounds great.
All right, thanks so much.
You're welcome.